Hi, everyone. We have quite a few attendees who registered, and we're going to wait to get to our maximum number here before we get started. I'm Kathleen Adelgaze, and I'll be hosting this webinar on behalf of the EMS for Children Innovation and Improvement Center. And so thrilled to have you all joining us on EMSC Day this week. Thank you so much for coming. Just another minute or so. And a little bit of housekeeping. Participants and attendees are muted, but we will have a Q&A that you can type questions in, and our two speakers will be able to address them during the presentation, as well as with some time for questions at the end. So we want to try to get everyone's questions answered. Also at the end, we will have both information about obtaining CE for your attendance today, and then a poll to give us an evaluation of the session and allow us to have make sure that we're giving good opportunities for education to people who are excited to hear this. All right. So we're approaching 5 after, so I'll go ahead and launch our webinar today. Thank you all for being here on EMSC Day, the Wednesday of EMS Week. And the theme for EMS Week this year is We Care for Everyone. And our talk today is going to be on pediatric pre-hospital seizures. I am Kathleen Adelgaze. I am one of the leads for the Prehospital Pediatric Readiness Project, and I actually also serve as my own state's EMS for Children program in Colorado. I'm also fortunate enough to co-lead the pre-hospital domain for the EMS for Children Innovation and Improvement Center, who has sponsored a webinar for the last several years on EMSC Day, really as an opportunity to kind of highlight the key work that EMS for Children is doing holistically to improve emergency care for children. Just a little bit of federal acknowledgement and disclaimer. The EMSC Innovation and Improvement Center is supported by a grant from the Health Resources and Services Administration. For more information, please feel free to visit HRSA.gov. The content here is not unnecessarily representative of any official views of or an endorsement by HRSA, HHS, or the federal government. As I mentioned, Prodigy EMS has been a fabulous partner, and we're so fortunate that they once again are offering CE for all those who are attending live. A video of this webinar will be housed on the EIIC website, probably be able to get posted within a week or so at the end of the week. And for anyone to be able to watch it later if they were unable to make it today or wanted to re-review any content. And so without further ado, I'd like to introduce our two speakers. We are so lucky to have these two brilliant individuals presenting today. First, Dr. Manish Shah will be starting us off. He is the professor of emergency medicine and pediatrics at Stanford University School of Medicine. He works clinically as a pediatric emergency medicine physician at Stanford Healthcare. And he is the principal investigator of the PEDIDOS study, which you'll hear about today in this presentation. He's also the principal investigator for the Charlotte, Houston, and Milwaukee pre-hospital research node of the Pediatric Emergency Care Applied Research Network, another key EMS for children investment. And he is the co-lead of the Prehospital Pediatric Readiness Work Group assessment work group, which helped develop and design the first national assessment of pediatric readiness for EMS systems. And not to be bested, Dr. Joseph Finney will be joining as well, and he will kind of round out our talk on pediatric seizures. He is the director of EMS at St. Louis Children's Hospital and an assistant professor of pediatrics at Washington University. He is the director of the Prehospital Readiness Program for the Missouri EMS for Children program, which is one of, I think, 5 or 10 in the country of a readiness recognition program established for EMS. And he also is the co-host of the Pediatric EMS podcast, which is a great opportunity to get additional EMS information focused on children. So disclosures here, Dr. Shah does have some grant support both from the National Institute of Neurologic Disorders as well as HRSA. And our objectives are here today. The first goal is to examine the evidence base and identify gaps in prehospital diagnosis and treatment of status epilepticus. Additionally, the goal is to review prior work and existing resources on pediatric prehospital seizure management, so information that you can take away with you that you can use today. And then finally, understand the future directions of prehospital status epilepticus research and care. How are we going to optimize the care of children? So I will pass it on to Dr. Shah to take it away.
Thank you, Dr. Adelgeist. So seizures are one of the most common reasons why an ambulance is called for a child. And so it's important that we understand the best ways to both assess and to manage these patients in the EMS setting. And so we'll start with a discussion of where we have been with the evolution of pediatric pre-hospital evidence-based guidelines, specifically with attention to guidelines for status epilepticus for EMS. And then we'll go from there to talk about what are we doing now and what's on the horizon. And so I'd like to start first with comment on this study. The pre-hospital treatment of status epilepticus, or FTSE trial, was the earliest well-known randomized trial in EMS for status epilepticus that evaluated the safety and efficacy of IV diazepam, IV lorazepam, and actually placebo as well, administered to adults by paramedics. And at the time, it was not yet established that EMS administration of benzodiazepines should be standard practice. And so it was for that reason that they included placebo in the trial. And so the FTSE study showed, as you can see here, that paramedics can safely administer benzodiazepines to control status epilepticus, and there was a lower rate of ICU admission in patients who received benzodiazepines. And you can see as well that there was a potential advantage to lorazepam over diazepam in this study. However, as many of you know who work in EMS, there are implications to storage of lorazepam on the ambulance due to temperature sensitivity relative to other benzodiazepines. This study, however, did not look at midazolam, which is now what's widely in use in the pre-hospital setting today. I also wanted to turn our attention to just diagnosis of status epilepticus in the field as well. And we know from prior research that identification of all seizures is not as easy as it may seem. And this was a study that was done in Switzerland, included 150 patients with status epilepticus that were brought by EMS to an emergency department and had an electroencephalogram applied upon arrival. And non-convulsive status epilepticus was actually missed by EMS 64% of the time, and non-convulsive status epilepticus was undetected 64% of the time, but for convulsive status epilepticus, that too was also undetected 15% of the time. So if you take the overall cohort, you see that there were more cases of non-convulsive status epilepticus, and overall 55% had a misdiagnosis in the field. And so there is ongoing work today to improve the recognition of status epilepticus, both in the emergency department and in EMS settings. But it's important to note that the recognition is the first challenge when it comes to managing status epilepticus, because we must recognize it before we can decide to treat it. So before we discuss evidence-based treatment of all seizures in EMS, it would be good to mention how the field has evolved when it comes to just the implementation of evidence-based practice in evidence-based guidelines in EMS. And so in response to the 2007 reports from what was then called the Institute of Medicine, now called the National Academy of Medicine, the National EMS Advisory Council and the Federal Interagency Committee on EMS, so NEMSAC and FICMS, they convened a panel of experts which then proposed a model for developing evidence-based guidelines in the pre-hospital setting. And this model involves 8 steps endorsed by FICMS and NEMSAC that begins with input of evidence from external sources, development of a guideline based on priorities from stakeholders, using a rigorous method to appraise the evidence, and then that is specifically contextualized to create a patient care protocol, which is then disseminated and implemented in the EMS community. And then it is important to determine the effectiveness and uptake by actually measuring it with the other quality improvement methodology or other research to determine outcomes. So in order to pilot this process, the National Pre-Hospital Evidence-Based Guideline Model process, back in 2009, the Emergency Medical Services for Children program joined forces with the National Highway Traffic Safety Administration to fund the creation of 3 evidence-based guidelines to pilot this model process. And specifically, they focused on 3 conditions. One was pediatric pre-hospital seizures. The second was pain assessment and management. And then the third was the use of helicopter EMS. And so I had the pleasure of working on the pediatric pre-hospital seizure guideline development when that work group convened. And so that guideline initiation process started in 2009, but it took several years for us to get to the point of protocol development in 2012. And then finally, along with the other 2 guidelines, these 3 were published as a supplement in pre-hospital emergency care in 2014. And the best evidence that was incorporated into that evidence-based guideline for pediatric pre-hospital seizure management, we also had to integrate evidence that existed in adults as well, because there are limited pediatric studies, specifically in EMS, and also there were limited studies in the emergency department as well to inform best practice. This study, however, the rapid anticonvulsant medication prior to arrival trial or Rampart trial, was published in 2012, and this actually included both adults and children. And it was a randomized trial of intramuscular midazolam and intravenous lorazepam. And the study demonstrated the importance of utilizing the intramuscular route. It involved over 900 patients, and it showed that although seizures stop faster once IV lorazepam is actually given to the patient, which is shown by at the top of the figure labeled B, intramuscular midazolam, when administered to the patient, was administered faster, and that's shown at the bottom of the figure as labeled A. And when you combine the 2 times for both administration of the medication and the time from administration to seizure cessation, that's the middle of the figure that's shown as C, you see that intramuscular midazolam led to faster seizure cessation in real world practice compared to IV lorazepam, such that there was a 10% absolute reduction in the percentage of patients that were arriving at the emergency department still with an ongoing seizure. This trial did not evaluate intranasal midazolam, but other studies do suggest that intranasal is also superior to intravenous, though the two have never been compared head-to-head, intramuscular versus intranasal. And so in the evidence-based guideline that we published in 2014, there were several things that we recommended to do and several things we recommended not doing. So those are listed here on the left. The things that we recommended doing were to check a glucose, and if hypoglycemic, to treat that, and to focus on using non-IV or IO routes of medication administration. So focusing on intramuscular and intranasal primarily for usage in the United States. And then as part of our evidence review, we also summarized that the buccal route, which is used primarily in Australia and New Zealand, was also an acceptable route. But we advise not giving medication by the rectal route when it comes to benzodiazepines, and not placing an IV or IO initially because it leads to delays in care, and also not requiring that online medical control be contacted for both the first and the second dose of medication due to the potential delay that could occur in administration of medication. And so I will just shift gears for a moment to talk about my experience in implementing evidence-based guidelines, because my first attempt at implementation of evidence-based guidelines in EMS did not focus on seizures, actually focused on a different condition, respiratory distress. So also funded by the Emergency Medical Services for Children program, I received a targeted issues grant back in 2010 and convened a multidisciplinary team of pediatric emergency medicine physicians, EMS medical directors, frontline EMS clinicians, and a parent. And we intended to carry this study out in collaboration with EMS agencies in 3 metropolitan areas in Texas, in Houston, Austin, and Dallas. And we had not actually chosen respiratory distress as our focus. We decided first to convene the group, look for a common condition where evidence existed and where EMS data was available. And through that process of brainstorming, arrived at a focus on respiratory distress, which when broken down into common reasons why an ambulance is called for a child, we've decided to evaluate the evidence for asthma, bronchiolitis, and croup. In addition, through a second targeted issues grant called the Pediatric Evidence-Based Guidelines Assessment of EMS Utilization in States, or PEGASUS, we took those initial 3 asthma, bronchiolitis, croup guidelines, the pain and seizure guidelines that were published in 2014, and then we created 4 more focused on airway management, allergic reaction, shock, and spinal care, and implemented all 9 of these in the Houston Fire Department and in several New England states in collaboration with the state EMS medical directors and protocol advisory committees in those states. And ultimately, these 9 guidelines were published when the National Association of State EMS Officials published their first ever model EMS clinical guidelines in 2017. And since then, there have been several iterations of updates to those guidelines. So taking these lessons learned in trying to implement guidelines, I decided to turn my attention back to seizures. And so that's where I'm going to focus the rest of our time, and specifically discussing the pediatric dose optimization for seizures in EMS study, or PD dose study, which is being conducted in the Pediatric Emergency Care Applied Research Network, which is also funded by EMSC and HRSA. And specifically within PCARN, there are 7 nodes or clusters of 3 sites that collaborate with one another. And HRSA, the Health Resources and Services Administration, has funded one of these specifically to focus on EMS, and that is the Charlotte, Houston, and Milwaukee Prehospital Research Node. And so I will be talking about what is the PD dose study about, why did we start this study, and where do we stand in conducting it. So, so to back up, as part of our preliminary work before we started this study, utilizing the structure that we had in our CHAMP node of PCARN, we decided to go ahead and implement that evidence-based guideline for pediatric prehospital seizures that was published in 2014, implement it in Houston Fire Department, in Mecklenburg County EMS in Charlotte, North Carolina, and in Milwaukee County EMS in Milwaukee, Wisconsin. And comparing before and after implementation, we saw an increase in the utilization of the preferred routes from 50 to 70% using the preferred intramuscular and intranasal routes. An increase in the administration of midazolam to when in the situation of when there was a paramedic witness seizure from 61 to 71%. But what we noticed was that the correct dose of midazolam was only being given half the time, and that did not significantly change even after implementation of the evidence-based guideline. And so the other things that we noticed as well were that 1 out of 3 of these patients were arriving to the emergency department still having an ongoing seizure. Half of them, as I mentioned, were getting the wrong dose. And if we look at were they getting under or overdosed, 70% of them were getting underdosed. And it took from the time of paramedic arrival on scene to medication administration approximately 14 minutes. And so seeing these things, we realized that there were opportunities for improvement. And we decided to dig a little deeper by interviewing paramedics in these 3 systems to understand what made it easy to follow their protocol, what made it hard to follow their protocol, like what stood in the way, and what were their solutions for enhancing adherence to the protocol. And they mentioned several things that were enablers, so things that made it easy to follow their protocol. And these included having decision support tools, like an app that informed them of the correct dose to give. Also having different routes of administration that were possible, so that, for example, if a child had nasal congestion, they could give the medication, the midazolam, by the intramuscular route instead. But they also noticed several barriers. And specifically, they noted that if the adult side of the protocol differed from the pediatric side of the protocol, not just from dosing, but from other aspects of management, that caused confusion. Also, if the protocol advised to manage a febrile seizure one way and a non-febrile seizure a different way, that was confusing. Or if it mentioned to treat a focal seizure in one way and a generalized seizure a different way, that also caused confusion, made it hard to remember all the details of what's in the protocol. So we asked them, well, then what would make it easier to follow the protocol? And they suggested 2 things. One was to simplify the protocol and to take out the calculations entirely. And so that's exactly what we're doing with the PD dose study. So this is the conceptual model for PD dose. So if we look on the left-hand side of the figure, we have the conventional dosing model of what is currently done, where a paramedic needs to calculate a dose. And so if you look at the bottom left, there's a cognitive load that comes from those calculations, as we heard from the paramedics. In addition, many of the paramedics still had this perceived need to place an IV. It wasn't 100% adherence. And so there was this thought that if a child is seizing, I'm supposed to place an IV. And so we're trying to address that, both of these things, by emphasizing through education and through revision of the protocol by entirely removing the IV and IO routes and only having the intramuscular and intranasal routes to remove that perceived need of IV access. And then also by introducing age-based dosing to eliminate the need for calculations. And our thought is that by introducing these strategies, that we will have more timely administration of midazolam given at the right dose, so that less children are seizing upon emergency department arrival. Now, we do hear sometimes concern when we train paramedics about a concern for respiratory failure if too high of a dose of benzodiazepines are given. We do know from prior literature that that doesn't happen when 1 or 2 doses of the right dose of medication are given. That occurs when an incorrect overdose is given, or more than 2 doses of a properly dosed benzodiazepine are given. And that some of the reasons why respiratory failure may occur with pediatric status epilepticus is just from ongoing seizure activity. And so our hope is that by having more timely seizure management, less kids will arrive to the emergency department having an ongoing seizure, and that will contribute to less morbidity, less respiratory failure, and improved and less mortality overall. And so the first aim of PD dose is to evaluate effectiveness, comparing the current EMS agency protocol for the EMS agencies that are participating in the study and comparing it with age-based midazolam to see which approach contributes to less children arriving at the emergency department with an ongoing seizure, and then also looking at safety from the perspective of respiratory failures. So specifically, we know from our prior work that 1 out of 6 kids that has a paramedic witness seizure has respiratory failure, meaning the need for bag mask ventilation, supraglottic airway placement, or endotracheal intubation, either during EMS care or within the first 30 minutes of emergency department arrival. And we believe that this will stay neutral. Although we expect an improvement in effectiveness, we expect that it will be just as safe. And so what we are doing is we have EMS agencies in 20 different metropolitan cities across the country, and we're including those that are 6 months to 13 years old that have a paramedic witness seizure and are transported to an emergency department over the course of 4 years, such that every agency starts out in the study using their current protocol, and then over the span of 4 years, every 2 months, we transition one of the sites to switch to the new standardized protocol. And we're excluding those that are pregnant, have a benzodiazepine allergy, or that are very small for age based on paramedic judgment. And this is a map that shows where the study is occurring in the 20 different metropolitan areas in the country. And as I mentioned, this is a study that's being done in the Pediatric Emergency Care Applied Research Network, and it has been cleared by the FDA. It is funded by the National Institute of Neurological Disorders and Stroke as one of the institutes in the NIH, and has received ethical approval from the University of Utah Institutional Review Board. So this is, in essence, the intervention. A paramedic arrives on scene, and after they determine that the scene's safe and has addressed airway, breathing, circulation, they ask the person on scene, the bystander, how old the patient is, and based on that response, they have the option to give 1 of 4 doses. So a 10 milligram dose if 12 to 13 years old in the study, which is 2 milliliters of midazolam using the 5 milligram per ml concentration. A 5 milligram dose, which is for the 6 to 11 years old patients, the 2.5 milligram dose for the 17 months to 5-year-olds, and the 1.25 milligram dose for the 6 to 16-month-olds. So this is what the protocol looks like if displayed in algorithmic form. So as I mentioned, checking for scene safety, airway, breathing, circulation, applying oxygen empirically, which was in most of the protocols anyway, addressing airway compromise if present, and then asking for that age, and specifically advising not to place an IV, not to place an IO, or check a blood glucose yet. Because we know from our prior work that about less than 2% of children that have a paramedic witness seizure have hypoglycemia. And so really the top priority should be getting that midazolam on board as fast as possible without delay. So if they're having an active seizure, they give that first dose of medication, as I showed on that prior slide. And then if there is an ongoing seizure or altered mental status after 5 minutes, then that's the point where they would check a blood glucose. And if the blood glucose is not normal, if it's low, they would treat that with per protocol. And then if it were normal, then they would repeat a dose of midazolam after that 5-minute point and transport to the hospital. So this is a study that has been approved to be conducted with the FDA regulations for exception from informed consent, which means that if the patient meets the enrollment criteria, they are automatically enrolled in the study, and then we notify their legally authorized representative after arrival to the hospital that they've been enrolled and give them options about ongoing data collection. So I will now go ahead and turn the presentation over to Dr. Joe Finney, who will discuss a wrap-up of the discussion about where we are, and then also proceed into discussing where we are going with pre-hospital seizure management for children.
Thanks, Manish. I really appreciate that. And, I think one way to sum up all of what Manish just said is that there are people working very, very hard to ensure that you have all of the right tools and evidence-based practice to treat children in the pre-hospital setting. And that really comes from working with these research networks like PCARN, and we're going to talk about a little bit more about that through the Emergency Medical Services for Children. But, I think one thing that's important is Manish has done, Dr. Shah has done a lot of great work talking about how do we effectively manage seizures in that sort of initial treatment period. What we know is that there's going to be a portion of seizures that do not respond to that initial treatment. Correcting the dose, administering it rapidly, effectively identifying seizures, all of these things are going to help shrink that population of patients, but there still will be a population of patients who continue to have seizure activity after the administration of appropriately dosed benzodiazepines. And it's for that group of patients where we're moving sort of a forward-thinking next steps in pre-hospital seizure management research is identifying how are we going to manage those patients with what we call benzodiazepine refractory status epilepticus, or BRSE. And that is kind of where my research focus takes over. And the model that we are really approaching this with is this slide was actually taken from a terrific and successful pre-hospital researcher, Dr. Robert Silbergleit, who found, who has really sort of said it the best, is that, EMS has access to benzodiazepines. If you continue to seize after benzodiazepines, then you're left with searching for reversible causes and rapidly transporting the patient to the emergency department. And what we need to do is identify an option, a treatment for patients before they get to the emergency department, moving that care out to take care of patients in the field, getting that treatment to them at an earlier and more appropriate time. And that's what you're seeing here. So don't wait to get that second line agent until that patient is in the emergency department. Move that care outside the hospital to the pre-hospital setting so that those patients can get effectively treated immediately and not have to wait and have prolonged seizures, and then hopefully prevent those downstream effects that occur from prolonged status epilepticus, which we'll talk about here in a moment. So where are we going with this focus on improving the pre-hospital care for that select group of patients? Well, we know, and Dr. Shah mentioned this a lot already, is that pediatric seizures in general are a time-critical diagnosis, just as with all other time-critical diagnoses that we know about. The longer a seizure persists, the more damage that can occur and the more harmful that can be to your patient. And so, there's significant neurologic injury, neuronal cell death. There's also the potential with prolonged seizures for respiratory depression or respiratory arrest. And we know from the established literature that somewhere between 60 and 70% of seizures will respond to benzodiazepines, and a percentage will not. So somewhere around 30%, I think that's maybe a little generous depending upon what you read, but somewhere around 20 to 30% will continue to have ongoing seizure activity. And it's for that group that we need to identify a second line agent that is effective in the management of those seizures. Well, they've done a lot of this work through the ESET trial, which is the established status epilepticus treatment trial, looking at valproic acid, phosphenitoin, and levetiracetam. And what they found in that group was that second line treatment after benzodiazepine, so for that treatment of benzodiazepine refractory status epilepticus, those agents combined were only effective in about 50% of cases to stop seizures. And that's, depending upon which drug you look at, it was somewhere in the high 40s to low 50s, but all right around 50%. So we're still only getting 50% of those patients successfully treated. And the question is it possible to do better? Are there better treatment options out there that we haven't identified yet? And can we get these tools to EMS clinicians so that they can effectively and rapidly manage these seizures in the pre-hospital setting? So what options are currently available for the treatment of benzodiazepine refractory status epilepticus? Well, a survey of 33 publicly available state EMS protocols found that only about two of 33, about 11% of them carried any treatment options for second line management. So very, very few of these protocols had an option for second line management. So basically, most protocols out there are saying you can continue to give benzodiazepines or rapidly transport that patient to the emergency department. And just like Dr. Shah said earlier, we know that when you give more and more doses of benzodiazepines, especially after 2 doses, so you start to give a third or even a fourth dose in some cases, then you are running the risk of respiratory failure in those patients. And so it's important for us to try and identify an alternative treatment. Ketamine is a potential treatment. And I want to step back for a second and just be clear about something. I'm going to talk about the benefits of ketamine in the management of prehospital status epilepticus. And it's important to know that this medication, like any other medication, has potential side effects, has potential downsides, if not administered in a safe and appropriate situation with appropriate patient monitoring. And I know there's many people on from all across the country and across the world. There have been high-profile cases where ketamine has been involved in patients having bad outcomes and even death. And so it's important to put this in the context of, just as with midazolam or any other treatment medications, you really have to think about this medication as a tool, but it's a tool that has the potential for harm and has to be treated that way. So ketamine is a NMDA receptor antagonist. And so this is a receptor. NMDA receptors are receptors that increase in concentration on the cell surface during prolonged seizures. So you can see there, that's a synaptic cleft. You have glutamate, which is a neuroexcitatory neurotransmitter being released with prolonged seizures, and an increased influx in NMDA receptors that help to bring that glutamate into the cell and then increase neuroexcitation and prolong status epilepticus and prolonged seizures and subsequent neuronal injury and potential harm. During that same time, as status epilepticus persists, we know that the target receptor for benzodiazepines, the GABA receptors, actually diminish in cell concentration, cell surface concentration. And so it's possible that early in a seizure, rapid effective management with benzodiazepines is going to be effective in stopping most of those seizures. But in situations where the seizures persist and patients have ongoing seizure activity, especially once EMS gets there, so thinking about a typical response time in the US, you're talking 9-10 minutes for an ALS unit to get on scene, and then getting to the patient's bedside, drawing up that medication, administering that medication. These are significant delays, as Dr. Shah showed in his previous work, just 15 minutes getting that medication on at the patient's side. So there's a potential that these seizures can be prolonged by the time you identify that the seizure is ongoing and need to treat it. And so that's why we need to identify potential options that can be utilized later in the course of status epilepticus. Well, the nice thing about ketamine is that it's already on formulary for a lot of EMS agencies in the United States. Dr. Shah talked about the harms of trying to give different medications for different situations and different doses and different routes, and medications that we use infrequently also are going to increase the potential for harm to a patient. Just it's the cognitive burden of trying to evaluate all of that in the moment is very, very challenging. And I would say that's one of the arguments against some of these medications like levetiracetam or fosphenytoin or valproic acid. One of the arguments against moving them to the pre-hospital setting is, well, they're going to be used relatively infrequently by EMS professionals, by an individual EMS professional. And so you want to avoid the potential that these, you haven't used it in a long time, you're forgetting exactly what the concentration is and dosing and all that kind of stuff. You want to try and use a medication that's more familiar. And ketamine is used for a variety of indications in a lot of EMS protocols. I know that varies from state to state on what can be done with ketamine, but overall it's used with relative frequency. It can be administered via intramuscular, intravenous, intraosseous routes. There's studies evaluating intranasal administration of ketamine. It has stable cardiopulmonary effects, so respiratory depression, cardiac complications such as cardiac arrest are also very, very rare as long as it's an appropriate dose of the medication. It's stable at a wide variety of temperatures. So really hot temperatures, really cold temperatures, ketamine is stable. It has a wide therapeutic index, which I definitely appreciate as an emergency department physician trying to care for patients. You want a medication that's going to be somewhat forgiving in case it's slightly overdosed or slightly underdosed. There's some discussion I saw in the chat about how to determine the exact weight for a patient. So we know that, age-based dosing is not always going to be 100% for different patients. And so having a medication that has some wiggle room that allows for a little bit of variability and still can be effective is really, really important. And there's growing evidence that this medication is effective in in-hospital management of what we call super refractory status epilepticus. So in the ICU settings, the neonatal intensive care unit, the pediatric intensive care unit, it's being utilized with more and more frequency for those types of situations. So the question is, can we move that treatment option outside the ICUs, the intensive care units, and move it into maybe the emergency department and the pre-hospital setting. And, you know, the question is, okay, well, are paramedics using it for this indication already? You know, in basically stating that we need the more impetus for doing research in this area. And we found that looking at the NEMSIS database, which I think most of you are probably familiar with, the national EMS database that most EMS agencies in the United States submit data to, we found that over a 3-year period, there was a significant increase in the amount of patient encounters for a seizure with which ketamine was being administered without an airway procedure. So the biggest complaint that you'll hear is that, well, how do you know that it was administered and not for rapid sequence intubation in the setting of seizures? And what we did was we controlled for that possibility and found that even then, over the study period, it was increasing. Now, one caveat I want to make about this data is that increase was a relative increase. So over the course of the study period that we looked at, there were formulary shortages. There were some high-profile bad outcome cases for patients who received ketamine, and the overall use of ketamine in the pre-hospital setting actually decreased. But interestingly, the relative percentage of ketamine use for that indication increased over that time. So even though ketamine was being used less, it was being used more for seizures over that study period. We looked at the ESO database, which was that blue line I just showed you, and published on that a few years ago, looking at the ESO database to establish, okay, how frequently is it being used for seizures in that data set? And as many of you know, ESO is another data collaborative that shares EMS and hospital data and allows for research to be done in that area. And it handles about 35% of all EMS encounters. So something around 8 or 9 million encounters a year. In this study, we found a similar increase of about 60% in the use of ketamine for seizures in the pre-hospital setting, even when you controlled for patients who had gotten an airway. Additionally, we saw it being used in situations where it was primarily about 90% of encounters were with midazolam. So thinking maybe this was used as a second line or third line agent after midazolam. And then we saw an increase in about 50% increase in encounters where it was used in isolation, meaning that no other benzodiazepines or anti-seizure medications were administered, meaning that it's being identified, or we can speculate that it's being identified by EMS professionals as a potential treatment option for this condition. And so, you know, retrospective reviews are great, but they are all retrospective. And you can see we had to do a little bit of wizardry to get things to work and to figure out exactly what's happening. And so the next best step is to do a case series. And so one study that was done in Florida was a case review of about 700 patients between 2015 and 2024, about 688 patients. And they looked at patients who received ketamine after. So the protocol change, let me back up for a second. Protocol change before, they only had midazolam and couldn't give ketamine. After the protocol change, they were allowed to administer ketamine after midazolam, after 2 doses of midazolam. What they found in that study when they compared these two groups, and they did what's called propensity matching, where they tried to identify individuals who were very similar in age and race and in seizure, or in age, race, weight, those medical problems, those kinds of things, to try and make it as pseudo-randomized as possible, right? So you're trying to identify 2 different patient groups. And what they found was that 94% of patients who received ketamine after midazolam had seizure cessation. And they found no increase in the need for airway procedures, meaning specifically in this study, endotracheal intubation, and no increase in cardiopulmonary complications in this study, which was cardiac arrest. So now increasing, remember I said there's that 20% of patients that we've looked at who have ongoing or refractory seizures after benzodiazepines. This lowers that in this study down to 6%. So shrinking that patient population pretty significantly. We published a similar study. The previous one was an evaluation of 688 patients, but they included patients who received ketamine were about 90 patients. In our study, we had about 42 patients who ended up receiving ketamine. And we found a similar results in our study. This was also a protocol change. So it was a protocol change to administer ketamine after midazolam, just like in the other study. And in our study, we found a 90.5% seizure cessation rate after the administration of ketamine. What's interesting, and don't take this to the bank, but in both studies, there was a small percentage of patients who received ketamine earlier in their treatment course. So in our study, there was 8 patients who received only ketamine, either for a medication allergy or for paramedic preference or for some other reason. In all of those patients, seizures were stopped with that one dose. So interesting, definitely not robust clinical research in any way, but evidence to support where this might fit in the formulary for the treatment of prehospital seizures. Additionally, in our study, we did find that there was about a 22% increase in the rate of hypoxia, and 43% of patients, a pretty significant number of patients, ended up receiving some type of airway intervention. Primarily, that was almost half of those, that was a BVM, and only 1 patient ended up intubated, and 3 patients ended up with a supraglottic airway. Interesting that 22% actually had clinically documented hypoxia, but 43% received an airway intervention. I think we're left speculating on why that might be, but one of the potential possibilities is the sedation that occurs with ketamine might appear to be respiratory depression or respiratory arrest by a paramedic, or there is concern for mental status dropping, the old adage, if their GCS is less than 8, they need an airway. So a lot of possibilities as to why this might occur, but interesting to show that the actual rates of hypoxia were relatively low. Most patients only required a BVM for a brief period of time. So that's kind of where we're thinking the next steps might be as far as the future of pre-hospital seizure research. We're optimizing, or Dr. Shah, not me, Dr. Shah is optimizing the early care and the management of seizures. And then we're thinking about next steps for how are we going to treat those patients who are refractory. Ketamine is an option. It's definitely not the only medication. I definitely don't want everybody to come off this call and go back to their agency and start giving ketamine for all your seizures. I want, this obviously needs robust, rigorous clinical research. And that kind of research is done through the Pediatric Emergency Care Applied Research Network, among others, where you can do these kind of clinical trials across an entire group of states and agencies and hospital systems. And that's one of the major benefits of emergency medical services for children, of which PCARN is one of the avenues through which it touches the pre-hospital care of children and the emergency department care. So, many of you have probably heard of the PCARN head injury rule. That was sort of put the PCARN network on the map, but was a tool designed primarily for treatment of emergency department patients to avoid CT scans. But that's not the only things that emergency medical services for children, and particularly the work that Dr. Shah and I are doing. There's education, training, lots of other tools that are available to you through EMSC. One of them we talked about earlier is the Pediatric EMS podcast. This is supported by EMSC through the Emergency EMSC Innovations and Improvement Center, excuse me. And this episode was with Dr. Shah talking about seizure management, a lot of the things that he covered today, but also some practical approaches to how to manage these patients. And one of the tools that is referenced in that podcast that's really, really important is if you go to the EIIC website, and there's a QR code there that you guys can scan, which will take you right to the website. You can identify these pediatric education and advocacy kits, or PEAKs, for a variety of different conditions. This one, obviously, status epilepticus is important for our discussion today. But if you click on one of those PEAKs, you'll see that there's a breadth of tools that you have access to. So there's webinars, videos, podcasts, protocols that you can use, simulation training that you can do in your agency. So a lot of you guys, we know from the EMSC pre-hospital readiness program that we've identified a lot of patients, or a lot of agencies, that improved pediatric readiness and improved pediatric readiness scores through use of education, training, and simulation. Here are tools you could use when you're trying to improve your own agency readiness for pediatrics, and you don't have to pay for it. It's a free open access tool. And what's really nice is there's bottom line recommendations. So you see at the top there is these EIIC TREC bottom line pediatric seizure or status epilepticus recommendations, which is kind of like the take-home notes for exactly what you need to know about the management of pediatric seizures. So if you don't have time to go through all of these different learning modules, which I encourage you to do, you can look at these bottom line recommendations, which are extremely important and helpful in the management of these patients. Here's a few other things that you guys will see listed. So there's quite an exhaustive amount of resources in each of these tools. And the SimBox, like I just quickly pass through, but the SimBox is one of those tools you guys can use to do actual simulation training. You don't have to create your own sort of scenarios. But you can see that EIIC has put together a lot of great tools under EMSC that you can use for these peaks. So there's suicide, status epilepticus, agitation, multi-system trauma, sepsis, all of these really important pre-hospital pediatric emergencies. You now have all the tools you need to make sure that your agency is ready to manage these patients. And these aren't just for EMS agencies, right? These are for hospital readiness, emergency department readiness. You know, if you're a critical access hospital, more in a rural community, and you don't see children as often, these are really important tools, because what we have shown in the past, or what EMSC has shown, is that hospital readiness improves pediatric mortality rates. So if the more pediatric ready your hospital is, the lower your emergency room mortality is for pediatric patients. And these are tools you can use to make sure that you're ready for the management of those patients. So Kathleen, I'll hand it back to you.
Thank you so much. Based on what I'm seeing in the chat and what I'm seeing in the QA, this was a really illuminating and interesting and provocative topic. Feeling powerless in treating a child seizing in front of you, nothing gets people more anxious. And so it's really nice to see the best evidence and how work is progressing in this way. Also lots of clapping and thumbs up and floating hearts. It's pretty impressive. For those who've been asking, the Prodigy EMS information there, it is how, and the QR code is also how you can get your CE for participating today. We are going to launch an EIIC poll as well. And so I'd ask that everybody take a few minutes to give us some real valuable feedback on this presentation. Next slide. Oh, sorry, I have control of the slides. I also want to send out a shout out to our over 7,000 EMS agencies who did complete the pediatric readiness assessment. The assessment's not open for at this time. It's hoping to come soon, but everybody can access the toolkit. You can use the QR code below. That toolkit is also linked to many of those peaks that Dr. Finney just showed everyone. And then I will hopefully have a few minutes here to answer any questions live that have come through the Q&A. There's been just a lot of great information about, or questions about the dosing for these medications. So I don't know, let me see. Their increase in use probably due to coverage in journals. That's, I think, the ketamine question that was brought up. And then kind of, I don't know, Dr. Shah, if you can talk at all about your knowledge or awareness of some of the color-coded syringes. Is that something that you're familiar with, or has there been any studies on that at all?
I have, I'd say, awareness that there are color-coded syringes as a safety measure to minimize pediatric dosing errors, and that have been studied in both simulation and in EMS. I think there is evidence that seems to support it from what I've read, but I'm not as familiar with the exact studies to quote them.
One of the questions also are, oh, the QR code, thank you for going back to that. I will say for the color-coded syringes, there was information. The biggest challenge is if people are using some of those that are packaged with the medications, there may be a risk of the medication expiring. That's one of the few challenges I've seen. I was going to ask Manish, there was a question, I don't know if you'd like to kind of review it for the entire audience, but I think people were asking about that range of dosing in terms and based on age. And I don't know if you have any additional insights into that before I know you need to go.
Oh, specific for PD dose?
Yeah.
Yeah, we created the doses based on the evidence-based guideline. The evidence-based guideline recommends a dose of 0.2 milligrams per kilogram, intramuscular, intranasal, or buccal. And so in creating an age-based dosing scheme, in order to minimize having like 10 different doses as options, because then that makes it more complicated, we made the decision that a dose of 0.2 milligrams per kilogram plus or minus approximately 20 to 30% would be acceptable based on our awareness of the literature. And so we utilized Centers for Disease Control growth charts to look at the 50th percentile weight for age. And that's how we determined the cutoffs that we used to come up with the 4 different doses. And that's why we don't have dosing for children less than 6 months old as well. But that was the reason. However, we are collecting data in the study on the patient's actual weight in the emergency department, and we will be calculating to see what is the actual dose that they received by EMS from a milligram per kilogram point of view, and then be able to do some sub-analysis that we've planned to determine whether there were certain dose cutoffs that seemed to be more effective on a milligram per kilogram basis.
That's really great to know. Thank you for that. I did want to make a plug for those who have asked that the EIC website is open access. All of the peaks, all of the toolkits, all of the resources are available for downloading and use. And you don't have to be a quote member of the EIC in order to access that information. Also, I wanted to kind of cover a question about pediatric cardiac arrest. We, at this time, have been working systematically in developing the various pediatric emergency and advocacy kits. And I believe high quality CPR and cardiac arrest will be another endeavor over the next few years to put best practices out there. There is the PD PART trial that was highlighted in the EMSC EMSC Day webinar last year, and we do know a large number of those children enrolled in the PD PART trial are victims of cardiac arrest, and therefore we hope to have more information about data coming out of that trial to best inform care. And seizures resulting from vaping cessation have occurred. Will the first line of midazolam by ALS have adverse effects for these patients? Manish, do you have a quick second to talk about midazolam for vaping cessation and or withdrawal? Or Dr. Finney?
Let Dr. Finney answer that one.
Okay.
That's a great question. I actually, like a lot of things in my life, I don't know anything about that. So I unfortunately cannot help. I'm not sure.
Same. Sorry.
Well,
I won't
think
pretend to give you an answer for something I don't know.
anyone registered or attending live will receive follow-up information, and we will take these questions in the Q&A that we did not have time to answer, and we'll get those questions answered and sent out as well. So thank you all. I know we're right at the top of the hour, and I know Dr. Shah had to leave to get to another EMSC Day presentation, and really, really appreciate your time and attention today. Thank you so much.